with Dr. Vanita Zahn.
With deaths from opioids once again climbing, in part due to the pandemic, the feds made a move recently that can help save lives. It now allows doctors to prescribe buprenorphine without the red tape that was once involved. Dr. Sheila Vakharia, Deputy Director of the Department of Research and Academic Engagement at the Drug Policy Alliance, joins us now to explain the importance of this. Dr. Vakharia, why is this so important that now docs don't have to, and it was a lot of red tape to be able to write these prescriptions?
So this is really important because buprenorphine was treated differently than other medications that doctors and other healthcare professionals use to treat various disorders. So whereas any doctor can prescribe cholesterol medication, diabetes medication, high blood pressure medication without any sort of restriction, if doctors wanted to prescribe this special medication, buprenorphine, to treat opioid use disorder, they actually would have to go through an 8-hour training and then apply for a special waiver by the DEA. And what we know is that doctors are very busy people. The more barriers you put in front of them, the more requirements you put in front of them, the less likely they are to be able to find the time to go through those procedures and then be able to prescribe that life-saving medication. And so in waiving this, basically waiving this waiver requirement, we are making it easier for doctors in their general practice to be able to start treating their patients with this medication without that kind of red tape.
Commonly known, it's Suboxone. And
that's one of the brand names.
Yeah.
Yes, absolutely.
Right. There's been concern about abuse. Wasn't that part of why there were so many hoops?
Yes, and some of those hoops were, and some of that, those concerns about abuse were actually grounded in a little bit of that residual fear that we have, the opioid phobia that we developed as a result of the kind of early stages of this overdose crisis. But one of the things we have to acknowledge is that actually buprenorphine isn't a full agonist and a full opioid agonist. It doesn't fully work like an opioid in the brain. It actually has more subdued effects. And so some of those fears were actually based in a little bit of misinformation and misclassification of this medication. And really this substance does have what we call a ceiling effect. So to a certain extent, it does have some opioid effects, but it doesn't fully, and that it doesn't fully work like an opioid in the brain. So some of that is actually based in a little bit of fear and stigma rather than actually what it does.
Are you getting a sense in the treatment community that, in fact, more prescriptions will now be written, that the doctors will be able to interact in this way with their patients?
I think in some ways, some of us, while we're excited about this, I think time will tell. What we do know is that the vast majority of doctors did not pursue the waiver training, and therefore we're not prescribing this medication. But what we do know is that highly motivated doctors already pursued waiver, and many healthcare systems and hospitals were working very hard to get doctors waivered. So I don't know who remains, who would be interested in prescribing this, but I do hope that those who had not been able to find time to get the waiver training may now consider initiating prescriptions. But I think time will tell. What we do know is that unfortunately, sometimes stigma against treating otherwise what would be perceived as more difficult or challenging cases has often been what has held back certain doctors from pursuing the waiver and working to learn how to treat opioid addiction. I hope that this will help to destigmatize and demystify some of the treatment processes, and that we will see more doctors prescribe. That's the optimistic view that I'd like to hold, but time will tell.
And how will this help save lives?
So what we know is that folks who have opioid use disorder who are maintained on medications like buprenorphine or methadone actually cut their overdose risk in half, because what we know is that when folks are being maintained on opioid agonists like buprenorphine, that it actually reduces their symptoms of withdrawal and reduces the likelihood that they're going to return to street drugs or return to use. And when we know that someone doesn't return to use, they're less likely to engage in the illicit drug supply, which we know is currently adulterated with fentanyl and other drugs that are increasing the likelihood of overdose. We also know that if people are less likely to go out there and use illicit drugs because they're being maintained on these medications, they're less likely to engage in other high-risk practices like reusing syringe or other injection equipment, which can increase the likelihood of getting skin and soft tissue infections, other bacterial infections. It also reduces the likelihood that they might share that equipment thereby transmitting HIV and hepatitis C. And we also know that folks who are maintained on these medications can then get some stability in their lives to pursue education, to pursue employment, to take care of their families and their communities, and to be more of a part of their communities. So absolutely, it is a life-saving medication.
And might they spend their life on this drug? Might they spend the rest of their lives taking this medication, this drug?
So what we know is that opioid use disorder for a lot of people is a lifelong condition that can be easily managed by medication. Like many folks are managed with diabetes medications for the rest of their lives, high blood pressure medications, high cholesterol medications. So buprenorphine is a safe medication for treating, for some cases, the lifelong kind of symptoms that people might want to manage for their opioid use disorder. So there are plenty of people who can safely stay on buprenorphine for years or decades, and there will be some who may after several years decide that they no longer need it and they want to give life without buprenorphine a try. But it's not up to us to decide how long someone stays on a medication for what is a chronic condition for many. That's something that they should decide with their doctors.
Dr. Sheila Vakharia, Deputy Director of the Department of Research and Academic Engagement at the Drug Policy Alliance. Thank you for schooling us on this, and hopefully many more lives will be saved and productive and fulfilled, really. Thank you.
Thank you so much.
And for more info on the Drug Policy Alliance, check under the link section here at WNYT.com. We'll see you next time.